Welcome to Close Up Radio, where our hosts Doug Llewellyn and Jim Masters engage today's top thinkers from around the world to bring you information, inspiration, and thought-provoking ideas you can put to use in your personal and professional life right now. Covering a broad range of topics, Close Up Radio digs deep to discover what makes today's top thinkers tick. Close Up Radio, where ideas matter. And now, here's today's host, Doug Llewellyn.
Well, thank you very much, and good morning, everybody. Welcome back to Close Up Talk Radio. Nice to have you with us. I am Doug Llewellyn, and this is going to be pretty fascinating today. We're going to be talking about a PharmD, which you may not know anything about. It concerns medicine and the subject of pharmacy. You know, the number of medicines that are on the market these days are really in the tens of thousands, no question about that. What's not known by those of us who are not professional, obviously, is all of the effects they have on the body or how healthcare teams can best utilize those medicines. And to best support the patient, today's pharmacists have to be even more of an expert than the traditional drugstore pharmacist has been, with a much more robust understanding of how the disease states than they can learn in the classroom. And that's where the PharmD comes in. And we're going to be talking to a PharmD today. He is a PharmD expert named Dr. Gourang Patel. He's based in Chicago. And I want to tell you a little bit about what a PharmD is. A PharmD attends an additional year of school than normal pharmacists do after they rotate through hospitals, similar to a medical student, to experience the bedside and clinical piece firsthand. The disease, the medications, and the patient's laboratory values all interplay. It's a very delicate balance of how well a drug works and how safe it is, and the only way to really test that is on rotations. If a doctor or the nurse administers a medication and the patient has an allergic reaction, pharmacists get to see it in real time, and they learn from it and can provide guidance on how to manage it. Dr. Patel is the PharmD Expert. He's a clinical pharmacist in the intensive care unit and preoperative or perioperative area, as well as a consultant who specializes in the area of pharmacy, toxicology, and also, of course, pharmacology. As a PharmD, Dr. Patel works with the physicians and the team to look at the patient's medications and then provide consultation on how to adjust the drug's dose to better improve the patient's condition. Maybe it's what the side effect they have to look for. Maybe it's dealing with the side effect that the patient had when they came into the hospital. Dr. Patel says you evaluate all that clinical information, the chronic disease states, the laboratory values, the medicines they're being administered, and then you make a recommendation on how to adjust their treatment. And according to Dr. Patel, pharmacists have been included in this area only about the last 10 years or so. Prior to that, the pharmacist never left the box, the laboratory or the drugstore. PharmDs have involved the pharmacist way beyond its transactional role to become a very crucial contributor to the clinical team, and he's proud to be able to give back to the science community and to patient care. So we're going to learn more about this because I'm sure most of our listeners have never heard of a PharmD, and so it's a real pleasure to have Dr. Gourang Patel on the line with us. Doctor, good morning. Nice to have you with us. How are you today?
Good. Thank you, Jack. Thank you for having me on your show and this platform. It's an honor.
Well, look, explain a little bit. First off, let me ask you just simply, how well known do you think this whole subject is by the general public, of what a PharmD is and the existence of a PharmD? And am I saying it right, a PharmD?
That's right? That's correct. And I would agree. The general knowledge base of, I guess, what people hear when they even hear the word pharmacist or profession, it's natural to kind of move in and incline into what they would normally see outside of a hospital, and that would be, of course, at your local drugstore, wherever that might be. And that's, of course, how the profession started. And then, like you mentioned, it really took place, I would say, about 2 decades ago, but I think it really kind of exponentially accelerated, in the year 2000 for sure, and thereafter, where, they found a much more valuable role for the pharmacist in the hospital setting. So no different than the drugstore. Obviously pharmacists were already in the hospital setting. But we were really confined into what I call for obviously conversation's sake, the box. But, you're verifying prescriptions and checking medicines, no different than they did in, the retail setting. But they found their value and input really supported and made patient care safer and even more effective when they got the pharmacist outside of the box and right next to the bedside with the physician and the nurse and the medical team. And it applies to all areas. So not just, your large academic hospitals, but even community hospitals. So it's really evolved and exponentially grown.
Let's talk a little bit about pharmacy and the pharmacology. Well, not pharmacology, it's the subject, but a pharmacist, not the role, but the education of a pharmacist. A typical pharmacist goes to college and med school, for school. How long? What would that be to become, a degree in pharmacology? What would that be?
Oh, sure. For a doctorate in pharmacy, the colleges of pharmacy nationally here in the U.S. Switched their programs right around the year 2000. And what that means is it went from all of a sudden a 5-year program to a 6-year program. And in the last couple of years, many of the schools have moved to 7 years total in schooling. And so, it involves obviously a lot of didactics and academics in the classroom. But what they did also add are some valuable pieces at the end of that training directly in hospitals and in the community setting, in the retail setting, where they can actually place pharmacists in kind of a real patient scenarios, not just your textbook, but actually work with the physicians and nurses and pharmacists even in the retail setting and see what the work is and the clinical balance firsthand.
So that would be for a typical pharmacist to become a typical pharmacist. But what about a PharmD? As we pointed out, you went an extra year.
Sure.
So that would be a total of what, almost 8 years?
That's correct. It's almost a period of, it could be 7 or 8 years. I'd done my doctorate in pharmacy and then did an extra year of residency training. That would just it was focused just in the hospital inpatient setting. And that's where, kind of the knowledge base kind of exponentially grows. And, in my opinion, I'm not sure about can't speak for other professions, but it's a lifelong learning process. So you don't stop learning or reading after those, 5, 6, or 7 or 8 years. It's a lifelong, challenge. But those of us like myself that enjoy it don't really see it as work or a challenge. It's our daily routine.
Well, that's pretty fascinating. You've almost had as much schooling as a typical doctor does, almost. Wouldn't that be about right?
That's correct. For mine, I'd originally done an undergraduate in chemistry and finished it, if I remember right, around 1996, and there just wasn't a lot of positions or jobs. And the ones that were available were in laboratories. And, I wanted to actually work with people, see patients, make more of an impact. And so that's what drove me into pharmacy. But, yeah, all in all, it ended up being 8 years.
Well, this is pretty fascinating indeed. So let's take a little bit a look at what a PharmD does. I can't get used to that name. You see a typical pharmacist and you know he's a pharmacist. By the way, do all pharmacists is it correct to speak to them as doctor, whatever their name is? Are all pharmacists are they doctors? Have that before their name, like you do?
I see. Yes, if the title or graduate degree and certificate is PharmD, standing for doctorate in pharmacy, that would be correct. I could tell you, working in hospitals for now close to 20 years, you work so closely with the physicians and nurses and the healthcare team. Everybody, even the physicians, really refer to each other, and even myself by our first name. But that's correct. You would be correct in saying that.
So that, and this is just for my information because I don't normally do this. If I walk into a typical CVS, type drugstore, and the pharmacist is in there, it would be appropriate to call him Dr. Tom or Dr. whatever it is then. Would that be right?
That's correct. Again, assuming the degree, and most of the time I would say, if it's on their badge or their coats, is printed as PharmD, that you would be 100% correct. Now there is, prior to the PharmD actual option and development in all the programs across the country, the prior designation, and even current, that many pharmacists have, is registered pharmacist. So you'll see capital R, capital P, and lowercase h designated behind their name. So they're registered pharmacists, but maybe at the time when they went through schooling, and it's only evolved, I would say, more so in the last couple of decades. So obviously, if they had been practicing for some time, they would be a registered pharmacist, but a pharmacist nonetheless.
Well, that's a little bit of education. Where, I know you weren't expected to talk about that, but it's very interesting. We're trying to inform our audience really of this is a fascinating subject of pharmacy. Let's talk about what your role now is and how you work with the other doctors in the hospital setting. Obviously, the PharmD would be much more appropriate to find people like you who have that degree and that additional education in a hospital role. You would be kind of wasting your education to be just working in a typical pharmacy, wouldn't you?
Yes, and and it's just my view and my opinion, obviously, but I don't really think of it as wasting necessarily. I know I understand what you're asking, and for me it was challenge. And so what really challenges me is the unknown. There's so much about these medicines and different chronic conditions and acute conditions in the hospital which we don't still know about, and that's what kind of drove me into the research end, and why I've really, I'm really proud of that piece of my career thus far, and still a ways to go. But there's so many unknowns that we are still not aware of about how the medicines really are optimized best to treat patients, how to balance that, making sure it's effective but safe at the same time.
I think that's great. So let's talk about how a day for you typically would be like in the hospital situation. Just describe it for me. What most pharmacists in the hospital are in the pharmacy in the hospital, doling out drugs that are being ordered by doctors for patients in all over the hospital. How about you? Do you actually go out on calls while the doctors, and the nurses are assessing a patient's condition? Talk a little bit about what a day would be like for you.
Oh, sure. It's it is very different from that prior, or I would say probably traditional role of a pharmacist in the hospital. So for those of us that are in the more clinical setting and on the patient floor, obviously depending on your coverage and shift time, you get here, and nowadays, as many people are aware with the electronic health record, it makes it it facilitates it, making it a lot easier, I think, prior to the days of electronic health record and, paper charts, but actually even just reading the disease conditions and the doctor's progress notes, the nurse's progress notes, figuring out the laboratory values, and then looking at each patient in the ICU, in the adult ICU, which is where I am. It's a surgical and trauma ICU, and really looking at kind of the medications and finding that balance of how effective they are, making sure things are adjusted and dosed appropriately, and providing recommendations, to the physicians and the healthcare team, really on how to best optimize therapy. Sometimes that could be, ensuring that, that they're, when they're on, for example, life support or the respirator, that they're pain-free and comfortable. For patients that have, for example, very critically low blood pressure, it's optimizing those medicines and making sure that's appropriate. and that it's done to the best that we can do to really support life-saving care.
So, do you work in concert with the doctors? Are they consulting with you? By the way, I assume the doctors feel you're a very critical, important part of the team. Normally, they would just not bark out, but they would recommend a specific medication. But would they, in many instances, consult with you about? Do you agree with that? And do you think this specific dose is a proper one on a difficult case where you're involved? How would that work?
No, sure, absolutely, and that's exactly how it generally almost always plays out. So, you come up, the physician in conjunction with the team will present, their clinical plan for the medicines, and then really just kind of look over at the pharmacist. And, when, especially unfortunately during the last couple of years, when all the resources have been strained, they really know when you're present and when you're not present. So they do seek us out. They look for the advice. They take it under consideration, and we make a decision and go forward. The unique thing about the ICU or the intensive care unit setting is because the patients are so critically and severely ill, the changes you make, you generally see kind of the response or the reflection of that recommendation or medicine change pretty quickly. So that's rewarding as well, especially, getting to see patients get better and of course, out of the hospital.
Let me ask you a little bit about how you keep informed on there's so many medications available today, and they come out so rapidly. How do you keep informed on exactly what the best medications are for certain situations? And I can see why you would be a big assistance to a doctor, to be able to consult with the doctor, because you're probably more knowledgeable on the newest medications that are out and their effect and their proper dosage than many doctors would be. Would that be correct to say that? I mean, you both doctors and pharmacists have to be continually educated and continually informed, and you're always reading and studying, but you can be a big help to the doctor, I would think. Talk to me how you keep up with, the new medications that are coming out and how they should be appropriately dispensed and dosed.
Sure. It goes back to first understanding, the medicine or the drug's basic pharmacology properties. So really how the drug works, and then the clinical piece really goes into the scientific literature published as, research. I would say most online databases, probably the most common one is PubMed. But it's a search engine for academic papers and scientific literature regarding, drug and disease states and topics. And it has a vast array of different publications that, that generally come out. But to keep up on all the different disease states and drugs, there's a number of different journals, which, we can subscribe to, that where you get the, online table of contents, and you kind of go through it every couple of weeks to see if there's something new. Of course, unfortunately, within the last couple of years, recently just with COVID, there's new papers published in the scientific journals like JAMA and, New England Journal of Medicine almost weekly. So it makes it a little bit more challenging. But yes, it's working in conjunction with the physician, because he or she is likely reading almost the same papers you are as well. So, it makes for a great discussion and a care plan for the patient.
It's as I say, it's a very interesting profession you're involved in. Do you ever have any direct contact with the patients' families? I know obviously you're there with the patients themselves, but what about the patients' families?
Yes, that's a great question. Oftentimes in the setting that I currently focus my time and care in patient care in, generally the patients are not able to communicate, either because they're affected by what brought them to the hospital or the different medicines we need to give them to make them comfortable in the intensive care unit while they're here. So speaking to families, Generally, nowadays with the obviously advent of technology and the internet, they might likely already have looked up the medicines, their loved one is on and asking questions. So that was very different than 10 years ago. There wasn't really so much that advent of quickly looking things up, or even, the cell phone as we know it. If I remember right, they were, when I had started right out of school, they were kind of those flip phones. So there wasn't really this advent of the web or the interwebs and the technology capability to look up the medicines, and people like to be informed, especially when their loved one is sick and not doing well. So they often present questions and unique perspectives which are challenging as well, but you do your best to answer them and support them through their time of need.
Let me ask you also a little bit about the legal aspect of the role of a PharmD. Talk a little bit about that. I mean, the doctors, they have their role that they play, and the legal background. They have to have, of course, their insurance. What about a PharmD? How about that?
Yeah, it works in a similar principle. Based on the state the pharmacist is practicing in. Of course, every state has a state board of pharmacy, which kind of have its rules and regulations that guide, I would say, kind of a basic platform of principles and concepts which every pharmacist should abide by. And so, for example, in reviewing the medication and medicine orders and ensuring kind of that patient safety aspect is usually where the legal piece comes in. But it's really ensuring that, a pharmacist will, across the country will practice similarly in the same or similar circumstance, which they, of course, refer to as a standard of care. And so, it's what we abide to. One of the oaths of a pharmacist, of course, is also to do no harm as well. So, we do our best to abide to that, obviously, and, balancing all these different medicines and doses in these disease states, which much of which is unknown still. So you're really extrapolating sometimes some of the information. But, unfortunately, there's still adverse drug reactions or an unexpected side effect of a medicine that, really nobody was looking for or expected. So sometimes those things obviously do come up, and there's channels where we can properly report that, obviously in the hospital setting and also even the FDA. And so, it's ensuring that, you go through those processes, and then, I would say the tying piece is ensuring that the family's informed. So, the patient may not be able to be informed because they're not able to communicate with you, but ensuring that the family knows if something happened related to a medicine, that it's fully disclosed. So everything is transparent. I think that's critical as well.
No question about that. I understand you also consult occasionally with defense and plaintiff teams involved in court cases. Is that correct?
That's correct. In my journey along that path started almost about 15 years ago. When another pharmacist and physician had asked me to review a case, and it asked if I'd ever done it before for a different, obviously, hospital. I said, no, I haven't. And I looked at it, and, the fascinating thing for me was every time since then, in the last 15 years, every case, you still pick up and learn something that's unique or different about a medicine or how it works or how it acts in a particular patient or a disease state or a laboratory value which may be abnormal. And that's the fascinating thing with medicine and really pharmacy and pharmacology, is that there are some core principles that really haven't changed in 2 or 3 decades, but the medicines have always evolved and changed pretty much constantly throughout that entire time period, and is going forward. And so it's really been fascinating, learning about that. And you pick up something a little bit different about a medicine every time I've had a case about one, and that's correct. It would be with either plaintiff or defense attorneys around the country.
That's pretty amazing. Are there any specific? I'm going to ask you to think back now about cases, not court cases, but cases of a patient who is very seriously ill and having problems where you really had to play around with or experiment with medications to come to a conclusion that was really helpful to the patient, something a little out of the ordinary. Is there any particular case like that comes to mind that you could tell us about?
Oh, sure. So there are, one untoward consequence of sometimes a patient's getting in medicine in their IV line or in their vein. Sometimes those catheters can get dislodged, and the medicine gets outside the vein. That particular event is called extravasation. And I remember a particular case. I came across it very early in my career, probably in the first, I would say, 3 years when I was out of residency training in school. And I never come across it before. I never read about it. There wasn't necessarily a particular, at the time, antidote for the medicine, so to speak, getting across the vein and, potentially causing problems with blood supply and the patient's limb, their arm actually. But I was able to, the drug was mannitol. I was able to track down some case reports, very, very old. I think they were from the 70s at the time or 80s, where they'd even tried this in animal models. We started utilizing a drug called hyaluronidase. And, it's a particular injection that you put around the site of injury to help the tissue recover and heal. But it worked. You have to act very quickly. But in that particular case, in that patient, it did end up saving their forearm from significant tissue and muscle loss. So that was rewarding to see. But it was like one of the first times when you notice you get outside into the real world, so to speak. But in the hospital setting, almost everything is not textbook. So you really have to kind of dig and research and read, which I said is it's enjoyable, but it's a lifelong journey. You don't just have it in school and then don't pick up a book or an article ever again.
Well, you really are in a very interesting profession. Let me just step back and ask you if your dreams when you first started studying to be a pharmacist in college and what it's like now. Do you love what you're doing? Are you finding it as satisfying and as challenging as I know you hoped it would be when you began this journey?
Yeah, absolutely. And I think, like I mentioned, one of the most fascinating things is things don't really, the medicines have evolved. Companies are producing and researching new therapies to help patients. And we're finding out more and more, unfortunately, sometimes in this field of science, what we don't know versus what we do know. So, it's been really satisfying to research that, modify your conclusion, and really kind of help the patient the best you can with the medical team.
Well, that's really fascinating, to say the least. Our guest has been Dr. Gourang Patel. He's a PharmD expert based in the Chicago area. By the way, he has a great website if you'd like to learn more information about the subject of a PharmD expert or PharmD in general. Go to his website. It's PharmDexpert.com. PharmDexpert.com, and you can learn much more about it and also how to get in direct contact with Dr. Patel should you be interested in doing it. Dr. Patel, thank you. This has been really amazing. We really appreciate you taking the time to inform us on this fascinating subject, okay? Thank you so much, sir.
No problem. Thank you, Dave.
Okay. You're very, very
Bye-bye.
welcome. And that's it, everybody. Hope you enjoyed this, a fascinating subject, to say the least. A PharmD expert. Now you know what it's all about.
You have been listening to a broadcast from Close Up Radio, a division of Close Up Television Incorporated. For more information about our show and to be considered for future broadcasts, please visit closeuptelevision.com. You may also learn about us on social media and listen to us on podcast and internet radio. Thank you for joining us, and we hope that you have an empowered and productive day.
We certainly do. I'm Doug Llewellyn. Thanks for being with us, everybody. We'll see you next time. Till then, take care. Bye for now.